I have no disclosure. So, as you have heard previously, acute liver failure is an accident in the life. And suddenly, there is a liver insult, which usually results in the vast majority of patients, and all of them recover spontaneously after several days or weeks. Unfortunately, in a minority of patients, the liver insult is persistent and is rapidly followed by other organ failures, including circulation failure, kidney failure, brain failure, of course, with hepatic encephalopathy, brain edema, and intracranial hypertension, infection. And all of this failure led to death with medical treatment alone. So it's a rare disease, a very severe disease, and you know that in the most severe forms of liver disease, liver transplantation is sometimes the only option. And of course, we have to think about just before the occurrence of multi-organ failure. The aims in the most severe forms of acute liver failure are the following. First, to accurately predict outcome with and without liver transplantation. The second point is to exclude patients who would not get benefit of liver transplantation. And lastly, is to offer transient transplant status to those with capacity to regenerate. So let's move to the first point. As you know, after a liver injury, after necrosis, the liver has the capacity to regenerate. And when the regeneration is adequate or sufficient, recovery is the rule without any long-term sequelae. In contrast, when the regeneration is insufficient or poor, the multi-organ failure occurs and a high risk of death. We know factors that are associated with poor regeneration, and they include steatosis, such as in patients with alcoholic consumption, advanced age, necrosis of the liver, massive necrosis of the liver, and the last point, fibrosis or inflammation, as it is observed in patients with autoimmune or with unknown hepatitis or even viral hepatitis. So when there is a low probability of regeneration, there is a very high probability of liver transplantation, since the recovery is not the rule in these patients. The indication of emergency liver transplantation is very challenging, and we must indicate liver transplantation not too early in order not to increase the risk of liver transplantation in excess. And in contrast, we have to indicate liver transplantation not too late in order not to increase the risk of death without liver transplantation. For many years, more than 25, we have strong and accurate criteria for liver transplantation, and you know that we have King's College criteria, UK criteria, which have been published by John O'Grady in King's College London, and Clichy's criteria by Jacques Berniaud in France. So these criteria are based on coagulation tests, factor 5 in French, INR in King's. Both include grade of hepatic encephalopathy, and lactates, blood arterial lactates, have been added more recently in King's College criteria in paracetamol-induced acute liver failure. So King's College criteria are the most used criteria worldwide. They are very robust, very accurate, especially in paracetamol overdose and all hyperacute liver failure. Maybe Clichy's criteria may be interesting in subacute diseases, such as in viral or autoimmune hepatitis. So the second point is to exclude patients who would not get benefit of liver transplantation. Of course, there are contraindications for liver transplantation, age over 70, the existence of malignancy or severe underlying disease, such as pulmonary, neurological disease or cardiac disease. Thirdly, uncontrolled severe psychiatric disorders, such as psychotic disease and AIDS. A most difficult question and unresolved issue is the too sick patients. We have strong and robust criteria for the indication for liver transplantation, but we don't have still yet criteria of futile transplantation or a point of no return criteria. So how can we define these criteria? We have conducted a study in our center a few years ago in paracetamol-induced acute liver failure, more than 137 patients. Among them, 35 had the indication for liver transplantation based on King's College criteria. In this population, 6 improved without liver transplantation, and 29 had a donor before 2 days. Among these, 13 patients have been transplanted successfully and were alive after transplantation, and 16 died just before or just after liver transplantation. This population can be considered as the group of futile transplantation, and all these patients had multi-organ failure, persistent acidosis despite hemofiltration, and high dose of norepinephrine above 5 milligrams per hour. So maybe these criteria could be used as a criteria of futile transplantation. So the last point is to offer transient transplant status to patients with capacity to regenerate. So maybe auxiliary liver transplantation may be a good option. Briefly, here are the principles of auxiliary liver transplantation. You correct liver failure with a graft, a partial graft, and after a partial hepatectomy, usually a right lobe hepatectomy, and there is a remnant native liver which has the potential of regeneration in the long term. And after, if the regeneration of native liver is sufficient, you can stop slowly immunosuppression. Here is the technique. Here the native liver with necrosis, and here the grafts. And then after, you slowly decrease immunosuppression, and then you stop maybe after 2 or 3 years. And how to monitor? No. There are conditions to consider auxiliary liver transplantation. The first point is that the liver should have a potential to regenerate, so it should be an acute presentation of ALF. Of course, no factors of poor regeneration on the graft, no steatosis, no inflammation, no fibrosis, and young recipients. Of course, there is an indication for liver transplantation and no contraindication, and if possible, moderate organ failure. Considering the graft, it's better to have a good quality graft without steatosis or fibrosis, and of course, an adequate size. Now, how to monitor after liver transplantation? We use two tests. First, scintigraphy, which assess liver function both of the native liver and of the graft. Here at 3 months, you see function of the graft, function of the native liver. Then you reduce immunosuppression. Here at M6, native liver graft. Month 15, here the native liver is higher than the graft. And at 30 months, only the native liver is here and no graft, since immunosuppression has been stopped. You can also follow the volume of graft of liver, both the graft and the graft and the native liver. Here, the first month. At 12 months, here the native liver, who is bigger than in first month, and here the graft. Month 18, here the graft is very small, and at 2 years there is no more any graft and only the native liver. So here are our results. In the most recent period, you can see that the survival rate at 5 years is about 70%, which is quite similar to overall survival that has been proposed in acute liver failure transplantation. Interestingly, immunosuppression winning is as high as 88% in our population of 40 auxiliary liver transplantation. That represents quite 10% of all of our liver transplantation for acute liver failure. So here are my take-home messages. Liver transplantation is the only option in patients with the most severe forms of acute liver failure. Most patients recover spontaneously. Again, it's a rare disease. And indications for liver transplantation are usually based on King's College Hospital criteria, but Clichy's criteria may be more accurate in subacute liver disease, viral or autoimmune disease. Medical or psychological contraindications for liver transplantation have to be ruled out. Criteria of futile liver transplantation should be better defined. And finally, auxiliary liver transplantation represents a good option in patients with a high potential of liver regeneration, provided that the surgical team is experimented.